feature in the bottom of the screen. And for now, I will hand it over to Nadine France, the Executive Director of Irish Global Health Network. Hi, Nadine.
Great, thank you, Hala, and welcome everybody on a beautiful sunny day in Ireland, which always feels good on a Friday. Really excited for our webinar today, talking about malnutrition and the increased risks, health risks during COVID. So I'm really excited to learn from our panelists and from our audience today. Just to introduce the speakers, we have Dr. Timothy Roberton. He's with us from Washington, D.C. He's a faculty member in the Department of International Health at Johns Hopkins Bloomberg School of Public Health. And Tim also works as part of the team there that maintains the Lives Saved tool, and he teaches courses on impact evaluation, NGO management, and statistical modeling. So we're going to be hearing a little bit around modeling from Timothy in just a bit. Also delighted to have Mary McGrath with us here. She's from the Emergency Nutrition Network, and she's also co-chair of the Wasting Thematic Working Group of the Global Assistance Mechanism on Nutrition. So very welcome, Marie. We've also got joined by Saja Mehajabin. I hope I pronounced that somehow okay. She's a nutrition advisor for Concern Worldwide, and she has worked in many settings in emergencies on transitional and development programs across many countries in Africa and Asia. And we also are delighted to be joined by Susanna Al-Moussaoui, a public health nutritionist and nutritional epidemiologist who's speaking on behalf of the NEDPRO Global Centre for Nutrition and Health at Cambridge. So delighted to be co-hosting this with DSAI, and thank you to Jacinta, who chairs that working group, for putting this together. So I'd love to hand over to our webinar anchor, Professor Rory Brewer, who is the former head of the Department of Epidemiology and Public Health at the Royal College of Surgeons in Ireland, just to kick us off. So over to you, Rory.
Right, so hopefully we'll get the screen sharing going. Is the screen sharing there?
Yep, it's perfect, Rory.
Right. Thank you, Nadine. So today's theme, nutrition, malnutrition, and food supply, looking at that more broadly, is an issue that we've actually briefly touched upon in two earlier webinars, the one on the UN responses, and more recently when we looked at some of the indirect effects of COVID-19. Here, most of you are familiar with this slide, and we've just done a comparator between last week and this week in terms of cases, deaths, and how these proportion to the populations of these countries. And we see that, as usual, we have Brazil and India, a high middle income, low middle income country, and then a selection of African countries. And they all show increasing rates of cases and deaths, but also, as we suggested, tests per million population is one indicator of capacity, and they're all ramping up their capacity to test. South Africa particularly, though we did question whether testing is an appropriate way for Africa, where most of the diagnoses are going to be syndromic diagnoses. So this is a slide we've had up twice before, and Tim will recognize it because twice we've actually used the pre-publication version of Tim's paper, which I see now is out in the publication version in Lancet Global Health. And here we're just focusing on we've got the three scenarios for deaths from children and from mothers. And I think the title of the slide is important, and I think I took that from Tim's paper, that modeling studies are not predictors of what will happen, but they're scenarios to enable governments to target their responses. And the three scenarios are there on the right. The first is if there's only small reductions in health workers and supply chains, and small reductions in people accessing health services. The second, if there are major reductions, and the third, if you include lockdowns that prevent people traveling at all. And we can see the scale of the scenario there, 2,300,000 deaths predicted by 12 months. And we had included this before, the causes of deaths, and I think Tim can talk to this, that actually wasting and protein energy malnutrition would account for not only 21% of deaths, but would be an underlying factor of deaths from a range of other causes. So you have the up-to-date reference there of Tim's paper. Now, what I thought, I'm conscious that each week we talk about Africa, and we only talk about Africa. And I have noticed there's been a participant from India over several of the webinars, and I thought we should put up this paper here, which is looking at the impacts on health, healthcare, and nutrition in India from COVID-19. And whereas in Africa, we tend to think particularly about malnutrition, protein and energy malnutrition. But what the authors here draw attention to is the impact of the pandemic locally on glycemic, on sugar control, increases in diabetes, cardiovascular conditions, low physical activity, and the shift in the nature of the food intake. And that these contributing to obesity, and all these are factors which are risk factors for poor outcomes from COVID-19. And then there are the indirect impacts of the pandemic on the national control programs, which we've looked at in Africa. And I think the common theme that comes across, I think we can emphasize it every week, is the impact, the disproportionate impact on the poor, on the slum dwellers. And in fact, some of the papers in this edition of Lancet Global Health are citing Tim's paper. So where are we going? Next one. I showed this slide before, and it's just worth putting up again. And this has, on the vertical slide there, we see the daily mortality from COVID. And the slide is to show two different factors at play here. First is the response and how effective the response is. And so the curves on the left there are where you have a very poor response or an unmitigated response to the epidemic, and you get these high mortality rates. But you see the mortality rates then vary depending on how effective the health care system is. So you have on the right there, with more effective healthcare systems, you get lower death rates. So that's a common factor to today's webinar and to other ones as well. So here was this is another slide that we showed. I think it's just worth drawing attention to again, which is just the links for poverty and vulnerable populations to the direct and the indirect impacts of COVID. And nutrition, food insecurity are in there. And they're in there at the bottom in terms of the comorbidities. Here is a new slide, and it's based on one of the papers in this global Lancet Global Health series, and it's drawing attention to two reports there on food crises. And as we've touched on once or twice before, the perfect storm in terms of food crises hitting sub-Saharan Africa, the chronic problem of armed conflict and insecurity, and now the locust swarms in East Africa. And again, how movement restrictions, the way that they impact on people is particularly around food supply, also food imports, and the wage loss and barriers to accessing services. And this is how it's framed in this paper. The pandemic from COVID-19 is being followed by a pandemic of undernutrition. So here, and thanks to David Weeklim for sharing this policy brief with us. This is just a policy brief from the UN that helps to frame approach to looking at food security and nutrition in the context of COVID-19. I won't go through this slide. I think I know Ellen will have these slides up quite soon afterwards. And I think it's better that we actually listen to the panel and see how some of these factors help to frame their experiences and their expert views of what's happening in low and middle income countries. So I've included the references at the end, and Ellen will be putting those up as we talk. So thanks, and I'm really looking forward to hearing all the panel. So thanks, Nadine.
Mm-hmm. Thank you, Rory. Thank you for a super job of just framing all of the issues for us as we kick off. So I'm going to move straight to you, Timothy, if that's okay. And Rory referred to the modelling study that you've recently published, which is really around the indirect effects of COVID on maternal and child mortality in low middle income countries. Can you explain a little bit about the study, why you did the study and what you found?
Yeah, well, thanks for inviting me to join this. This is really exciting, and thanks, Rory, for doing such a great job of introducing, what I was going to talk about. I feel like I can now jump to the discussion of it a bit more, so that's great. Yeah, I think the listeners will already have perhaps some idea, but basically we know that from past outbreaks or pandemics that there are issues related to the virus itself or the kind of concerns of the direct concerns of the outbreak. But because of the outbreak, for various reasons, other things might happen that could also cause health issues, notably the disruption of health services. So people not being able to access routine healthcare, right? And so we sort of knew that early on that this was likely to happen. And so we ran our own modeling to see, what the potential indirect effects might be with COVID-19. So we set up a number of scenarios, and as Rory said, we weren't trying to predict what was happening. We were simply trying to say that, if certain things were to happen, what then would be the consequences for maternal and child health. So we set up 3 scenarios of different severity, and we kind of left the duration of it a bit open because I think it's still unclear, how long the kind of shock is going to last for different countries, different experiences. In general, as we were doing it, we were thinking of 2 broad pathways by which the pandemic might indirectly affect child and maternal mortality. The first pathway, as I said, was around the disruption of health services. So people either not being able to access care, not being able to get to a health facility, not being able to afford health services, perhaps being afraid to travel or afraid to go or fearful, making different kind of calculations around whether or not they should seek care. So access side, but then also on the supply side, potentially issues in the provision of care. So health workers themselves, perhaps not being available, perhaps being out sick, being distracted, or having to deal with other aspects of the pandemic, or in terms of medicines and equipment, maybe supply chain issues also there. So various factors that could mean that kids and pregnant women aren't getting the routine essential health services that they usually would. So that was one big broad pathway. And the second pathway that we tried to examine, which I think we're going to unpack in this webinar, is the broader socioeconomic effects and how that might eventually lead to increased undernutrition in kids, and potentially overnutrition, as if we think about other factors. Anyway, so the thinking there was that because of the pandemic, people might not be able to have access to food systems disrupted, agriculture disrupted. Also, people might have lost incomes or less potential for households to spend money on food. And so as a result of that, families are not able to access or afford food. That will result in kids perhaps not getting as much food, being undernourished. And we know that wasting itself doesn't necessarily kill kids, but it increases the susceptibility of kids to die from other infectious diseases. So pneumonia, measles, meningitis, and dying from diarrhea. So that's another pathway by which kind of, that we're concerned about. And we modeled various scenarios, and Rory presented the results. And I think just to sort of conclude, we've the paper I think has been received very well, but I'll be the first to admit that what we did was highly speculative, and that I think a lot remains to be seen in terms of how countries will respond, and whether or not we can mitigate COVID itself while also allowing for routine health services. And if we can do that, perhaps the effects won't be as bad as we predicted or we estimated.
Mm-hmm. Yeah, thank you for that, Timothy. I know that at the moment I'm working with a wonderful group of people in Zimbabwe who are living with HIV, and they're down to 1 meal a day at the moment. So I think that's it's a very real situation for countries that are that have those kind of restrictions. I wonder, could you say a little bit? I mean, obviously, when you were going through looking and putting together the modeling, were you able to identify any programs, specific programs that could have a significant impact on improving the child and maternal mortality, particularly ones that maybe if they were modified, they could have a good impact?
Yeah, so we didn't necessarily look at programs in terms of particular kind of initiatives, but I suppose we're thinking more about the interventions, or what are the kind of treatments, or kind of health services that are important. I mean, around the world, most kids under 5 die from either pneumonia, diarrhea, or malaria in malaria endemic countries. And we have good treatments for those that are quite effective. So antibiotics for pneumonia, oral rehydration solution, and maybe zinc for diarrhea, and then ACTs for malaria. And so it sort of makes sense that in our modeling efforts, we found that if kids are not able to get treatment for those 3 illnesses, then that's going to likely contribute a great kind of greater proportion of the potential additional deaths that we might see. So particularly, I think antibiotics for pneumonia, and for neonates as well, for young newborns, sepsis, getting oral antibiotics to treat that. So that is, I think, important, and that if we were to have to prioritize interventions, perhaps we would focus on that. But I think intervention delivery is sort of complicated, and it's perhaps not very helpful to think of specific things. I think we're better to think about what strategies we want to, how we get treatments, of any treatments, to kids, maybe through using community health workers, or maybe through modifying provision of care at facilities. But the other one big factor that we looked at, and I think which we'll go on to talk about, is wasting as a potential contributor to child death. And in our scenarios, again, highly speculative, and it's in some ways our results are driven by the assumptions we chose. But we found that the greatest potential cause of child mortality was an increase in wasting. Maybe I'll just say that for those interested in maternal mortality for the mother, the biggest the things that would lead to the greatest number of maternal deaths would be a reduction in emergency obstetric services. So again, mothers around the world often die from postpartum hemorrhage, from eclampsia, preeclampsia, and maternal sepsis. And again, we have treatments for those. So if mothers who do experience a complication in childbirth, if they're not delivering at a facility or with a skilled birth attendant or with someone who can provide treatment for those, then they're more likely to die in childbirth. And so those 3, and just having a clean birth environment as well, leading to maternal sepsis, those sorts of issues, I think, are the programs or the kind of health interventions that we need to prioritize for moms.
Yeah, thank you, Timothy. And I think we'll hear from some of the later panelists about some of those interventions as well. Just one last question for you, just came in here from Niall Roach. In the modelling, did you factor any disruption to wash services as a key component of primary healthcare?
So that's interesting. We've had that. I think our work, I think, has been well received, but a few people have come out and talked about some of the things that we didn't model, and I'm very happy to talk about them. We didn't look at changes in breastfeeding, and I think maybe if we're talking about nutrition, that might be something to talk about. We didn't look at some of the long-term effects, for example, in reduced contraception on fertility and population growth, or on stunting or other longer-term things, and we didn't include WASH in the thing. And our thinking at the time, this was quite early on. I mean, March, it was a few months ago, and it's amazing to think how much has changed then. I think as we were just putting together our assumptions, we thought that, wondering, is there any reason to believe that piped water into the house or improved water sources would change, and perhaps not? Would hand washing change? Arguably, hand washing might go up. So I think we thought best just to leave or exclude WASH from our initial analysis. But I know that a lot of people have been talking about it, particularly in humanitarian situations. And I'm certainly happy to be convinced that that's something that is we should look at, and certainly it's important regardless. So
yeah. Yeah, good. Okay, Timothy, thank you for that. We'll try and circle back around again. I think for now, I'll move over to Marie, if I can. And Marie, you know, the Emergency Nutrition Network, you're well used to working and responding to emergencies of all kinds. But I know specifically around COVID, you've done a lot of work in trying to fill the knowledge gaps around nutrition in COVID, and really trying to understand what the core issues are for people in communities in low middle income countries. What are some of those key issues that you've discovered from your work so far?
Thank you, Nadine, and thank you for giving me the opportunity to join this conversation. A wonderful selection of panelists. And just to set the context, so ENN, Emergency Nutrition Network, we're a UK-based charity based in Oxford, and we actually began live at a desk at Trinity College in Dublin nearly 20 years ago. So I always feel I'm coming home when I have a little visit like this. So
you're welcome. So welcome.
Yeah, nice to be home. And I'm going to really touch on the work ENN's been doing as part of this global technical assistance mechanism on nutrition that Nadine mentioned, where we're very actively supporting knowledge management, so real-time and longer-term learning, and then helping to develop consensus-based rapid guidance development for the really tricky programming questions that are coming up by those working on the front line in countries in the nutrition and COVID response. And just to explain quickly, the GTAM is a sort of common global mechanism that was set up maybe about a year ago. It's endorsed by over 40 global nutrition cluster partners, and the aim was to provide really systematic, predictable, timely, coordinated technical nutrition assistance to those working at country level. UNICEF is the cluster lead agency with nutrition, leads it together with World Vision International, and ENN is the knowledge management partner with that. And it's really had to surge on COVID-19 and nutrition. So there's really been a big galvanized effort across NGOs, UN agencies, experts, practitioners. So I'm really reflecting some of this, the experiences of being part of that work. And just to say for ENN, our work has been supported indeed by Ireland, by Irish Aid, long time, and by Ellen Crook Foundation and by UNICEF. That's really allowed us to sort of step up on this front. So talking about challenges, multiple, I could go on forever, and I think Tim has touched on some of the key ones as well in his opening session. But you know, we're seeing disrupted food systems, agriculture, markets that are affecting the food security of families, and really increasing the risk of undernutrition or making it worse for those who are already undernourished or wasted. The disrupted and sometimes suspended health and wasting treatment services has been a big factor. So partial or full closure of health facilities. There may be some health facilities which have been used as stabilization centres for children who have complicated wasting, may lack appropriate PPE. And so it's been a real struggle for programmers to do, well, how do we manage that? Do we admit them? Do we not admit them? We're actually getting reduced capacity because of the distancing required between beds. So actually you're reducing the capacity of these stabilization centres. Getting health workforce people who may have been involved in, say, wasting treatment, being repurposed where COVID is seen as a priority. So they've been taken out of sort of nutrition services. The health facilities may not have the necessary triage, and you may have outpatient centres for treatment of wasting, may not have sort of the screening. And so they're screening these children and they're saying, well, we screen them, but what do we do with them? Do we treat them separately or what? So it's real practical problems. The reduced access to treatment and facilities. So where you might have had a child coming every week for follow-up and getting a supply of ready-to-use therapeutic food as part of treatment, now is saying that you mustn't attend or reduce frequency. And so programmers are trying to figure out, well, how often should we be coming in? How do you get that balance of risk between them coming and the exposure of risk, or them not coming for a long time and the risk of them deteriorating? So real challenges around that. And then how you screen children. Because, you know, a big thing around nutrition has been screening in the community, getting kids early. Now, if you're not able to do it, and things like using, even at a facility level, using scales carries risk. You're talking about disinfecting scales. and the contact and the close contact with staff, and so also you're not getting the same community outreach, so you're not getting that contact or reduced contact to screen children. So it's been a real challenge. Well, how do we access those children, and what do we do in the meantime? And the COVID-19 pandemic, and I think reflected in Rory's slides, affects many countries around the world, but many of them with fragile health systems already, and or are affected by humanitarian crisis already, or severe food insecurity already. So this is just another thing on top of that. And we sometimes also forget that many of those affected in these sort of challenging contexts live in urban contexts where physical distancing is just not possible. You've got refugee contexts like the Rohingya crisis in Bangladesh, where social distancing and physical distancing is not possible. So that creates a real challenge. And how, if you've got people would normally be coming to, say, a supplementary feeding program where it is about convening people together, well, what do you do in that circumstance? The scenarios is very interesting that we hear from Tim, because that's one of the challenges that we're seeing from programs in different contexts, is lacking data on caseloads, and how do you project or anticipate and capacitate in order to respond. Pre-positioning of supplies, how much supplies should we position for critical foods and supplies for treatment of wasting, and indeed interruptions in these supplies, because markets and production and supplies and transport have been affected. So even the essential nutrition supplies for treatment has been a challenge. I think there's also been sort of gaps or challenges in actually applying and interpreting the evidence and what evidence exists when it comes to programming. And a good example comes from the breastfeeding front, which is we know is fundamental to child survival. It helps to protect against the infections, a key source of nutrition, and fundamental for maternal health as well, and for infant development and growth. But there's been a lot in the response, a lot of misinformation and misinterpretation of around breastfeeding in the context of COVID-19, and it resonated a bit with the HIV scenario, where the risk of transmission dominates the risk in people's heads. And so the fear of COVID transmission and some sort of miscommunication, misinformation meant that mothers and infants were being recommended in many countries to be separated at birth. And this, creates a huge problem, and there was no grounds for it. You could see where it was coming from. And so there's been a lot of action to try and address that, and work by WHO to generate frequently asked questions, lots of communication on this. But it just shows, with this so much evidence and so much information, the misinformation and who you go to is really, really important.
Marie, how in the context of what you've described, I mean, there's so many complexities and so layer upon layer of issues and challenges. How has the network been able to respond to some of these issues? And obviously, like everybody, still on the fly, just trying to do the best you can. How have you responded?
Yeah, so as part of the GTAM, what is convened is, so to give for an example, when there's a lot of these questions and these real programming realities are coming in through various channels, through help desks at UNICEF, through the country programs, through an online forum that ENN manage. So they're escalated, they come to the global technical mechanism, and then if there's guidance that could be applied, they're reflected in briefs. They go onto the GTAM website in a sort of a Google document. They're distributed back out. But the tricky programming questions, that is not an easy answer. This is escalated to the thematic working group that Ian co-chair. And so then we have a group of sort of advisors, experts from agencies, etc., who quickly convene and say, here's the question, okay, what are the benefits, the risks, what do we know, what could we apply? And we develop a quick peer consensus. We consult with externals like WHO, with experts, and we come up with a programming answer, which we then put out again. It may go into a brief, or it goes on to the GTAM website, and we disseminate it out. And also what has been formed is what's called, for several areas, so on wasting and also on infant and young child feeding and nutrition information systems, is a programming adaptations team. And this is just a small convened group, but we're actively constantly trying to find out what program adaptations are happening. We're in contact with field teams. Tell us what you're doing, because a lot of the innovation is happening on the ground. So people are learning by doing. And so we're actively capturing that and trying to create a feedback loop, and then sharing this in a sort of a live programming adaptations document. So there's a sort of, and I think trying to curate as well. So for example, WHO, the Global Technical Mechanism put out a brief on wasting at the outset, maybe 2 months ago, and one on infant and child feeding. Now that is, the original ambition was like every couple of weeks, they'll put out a new brief. But actually we thought, God, there's so much going on. If people are getting briefs every 5 minutes, people just look at the first brief and don't. So we really want it to be timely. So they're updating a new one on the wasting, which will be out in the next week and a half or so. It will reflect sort of, it'll be informed by what's been happening. It'll be informed by programming adaptations that have been happening, and it will be distributed out. So that's what sort of the effort that's galvanizing around trying to do that.
And I see already, you can see Brita Gahan there from Concern is just saying that the information that you're providing is very, very useful to organizations like Concern. And I know it must be, you mentioned yourself, Marie, the evidence and you know, how are you, you know, you're obviously working alongside WHO and UNICEF and others, but how are you responding given that the evidence is, you know, constantly evolving and changing? And also how are you contributing to that evidence base as you go along?
Yeah, it is. It's what we're wrestling with every day. And I think a good working example, I think, was with the breastfeeding issue, where we are seeing real potential damage and loads of questions. So a few of us, the agencies, Save the Children, MSF, ENN, several, became part of a group with WHO, and WHO were getting similar questions from their countries. And so we put our heads together, came up with frequently asked questions that would address these, and then worked very, very closely. WHO are doing a great job in terms of you know, having to be really on top of it all the time, in terms of, it's just mesmerizing what's coming out. And so we are working very closely with WHO, and just so trying to make it sort of, it's very practical stuff that we're putting out. We've done things like information notes. I think also what we're seeing is that there has been innovations and some new developments in nutrition recently, sort of simplified approaches to managing wasting, sort of reduced dosages, use of mid-upper arm circumference to identify children, but they've been done by families and by mothers, not by a health worker. So actually these things are being used as well. It's actually catalyzing some of the changes that would be maybe a bit slower to take on, but it's like all of us now using Zoom, we're suddenly all au fait with it. The same thing is happening. And so maybe the silver lining in some of this is that it is catalyzing change that may mean more access, mean more community. We're also seeing innovations around using mobiles and WhatsApp and remote. How do you remotely support a community health worker? And how practical things like, if you were to ring up a mother, you can't access them, what are the 5 or 6 questions you could ask her that would help you identify, does she need to bring her child to a facility? Is this child at risk of, or is this child wasted or not, without you actually being able to see them or touch them? So really challenging things, but that's what we're getting people's heads together on. And then we put it out as an information note. And I have to say, you know, I think just to give an example, so Concern, who are very involved as part of the group, indeed they developed a guidance for their programming, which was really helpful for, you know, on COVID-19, and they shared that with the group, and we're like, God, great ideas in there, let's share that. So there's this constant loop, there's a real openness to learning and to capture what is going on.
Yeah, wonderful. Marie, thank you so much. That's really interesting. And many of the resources you referred to there, we've put in the chat box for people to access. And also just encouraging all the attendees to ask questions and to make comments as we go through. So I'm going to move, as you were speaking about Concern, I'm going to move over to Saja, and just to say, you know, obviously we're very familiar with Concern's work, and, you know, you're working among the work that you do, you work in many countries that face extreme poverty, high levels of malnutrition, combined with fragile health systems. What would you say has been the biggest challenge, or some of the biggest challenges for Concern relating to COVID, and how that's compounded the issues around malnutrition?
Thank you, Nadine. I think most of the challenges has been outlined by Murray like very nicely, and they also apply to concern, because these are the challenges that we are facing every day and responding to this crisis that are now like tremendous. So one of the things that initially we struggled is to like ensuring that how we balance the health risk of COVID with the, against the normal mortality risk that the children are facing every day due to malnutrition or vaccination or, other forms of illnesses. So making that balance was the first, actually, the thing that we struggled. Like, how can we ensure that we are not putting our staff or the children or the beneficiaries at risk, but also provide services to them and continue the services, the malnutrition services. So that was the first challenge that we faced. But fortunately, as Marie already outlined, that there was a very big, the global coordination mechanism worked very, very well. And it did a tremendous job in coming out with recommendations and guidelines within a few weeks even. And that actually also helped us to plan our responses. The thing that we are still struggling, and I hope that we will find a solution in the near future, is to how can we continue the services in the community, the things that we used to do, like identify the malnourished cases in the community through screening, or doing some preventative work through focus group discussion, or mother-to-mother support group or care group structures. So those are the things that actually are stopped right now, and we are struggling to find a solution. Because most of the countries that that concern is working is very fragile, and some of the innovation and technologies that have been coming out recently, which includes mobile phones and WhatsApp, it might not be applicable to most of the areas that we are working in because of the network issues and because of they don't have any mobile phones in their hand. So we are still struggling to find out how we can ensure that the community-based services that we used to do, that ensured that we are kind of getting the cases from the community, we're tracking the children, we are making sure that the preventative messages are going there. It's actually are stopped now. So we are still struggling to find a way to ensure that. Mary already also mentioned about some of the knowledge gap, but I would say that for us also one of the biggest knowledge gap would be to kind of understand the impact of COVID on the children who are already malnourished. So when we were treating the children, what are the risks? Like if they if they are getting COVID, what would be the best treatment protocol that we should use? What should be the guideline? And also if they get the COVID, will their symptoms be more severe? And how would we manage it? So these are the questions that are still unanswered. And these are the questions actually we are also coming from the field and asking us what we can do if we find a case with COVID and malnutrition. What are the protocols we should follow? So this is an area that I think we are working on to find a solution, but there's still a gap. Another challenge I would say is kind of to balance between the treatment and preventative activities that we used to do. So right now we are mainly focusing on life-saving treatment, and all of the preventative activities are kind of are going on a slow pace now because of the movement restriction and other restriction. But if we don't find a solution soon, we can see more people, more children, vulnerable group who will become malnourished. And above all, the fragile health system that we are working with, that they are not kind of prioritizing essential health and nutrition activities. So it's kind of very difficult for us to even talk to the government and make them understand the importance of the continuation of the essential services. And that's how it would have an impact if we don't go for it. So these are actually some of the major challenges Concern is facing right now. I can go on for ever.
I hear that.
Yeah, so I'm going to stop here.
Well, I wonder if I could hone in on, I mean, we've heard in previous webinars just the importance of essential services, essential health services. But if we're really thinking about essential nutrition services, Marie mentioned, for instance, some of the innovations that are just, organically coming up, like mothers, mothers being involved. Have you seen anything from programs so far, from Concern programs?
Yes. I would say like that's one of the first thing that we did actually, that we actually, when the crisis was starting, we thought that we need to continue our services, and the best way to do is to go for no touch approach. So Mother MOAC, empowering mother to take MOAC was always there. So what we did is like we brought it into the facility base. So what we did we used the dolls on the or some kind of dummy to show mother how to measure the children, so that we don't have to touch the children. So this is a kind of an approach we have like started from like very early when the COVID actually started. So this is an approach that we already implemented. We implemented very successfully, and it's kind of still ongoing. So that's how we are providing the treatment right now. We don't touch any children. We don't do the measurement.
Oh, I think we're losing connection with Sajja there.
And
there
another thing actually we initiated like in the beginning of the crisis, that we set up trial station in like every health facility, so that we can identify the cases and isolate them according to the government protocol. So that's an area that we invested from the beginning, and yeah, it paid off.
Wow. And Sajja, I know it's, a strange question, but do you see any opportunities? Always, this thing of looking at opportunities in crisis. Do you see any opportunities for attention and resources around nutrition, around malnutrition from this crisis?
I think, like right now, the way the crisis is unfolding, if we want to respond now, the things that we need to do, like we can see many opportunities right now. For example, we are focusing on how to bring services more to the community, how to strengthen the health system, that they can predict and respond to services. So we knew it, but now we know that if we don't work on this, the future is very, very scary. So this is an opportunity for us to realize again that investing in system strengthening should be the priority in the fragile countries. Even in the fragile countries, the preparedness and response plan, the importance of data, the importance of predictive analysis, it's more than ever. And it's an opportunity for us to build the system, and through which we can respond to the future emergencies. And also the way we are adapting all of our program to make it more closer to the community, empowering the caregivers so that they can actually take charge of the measurement and all these treatments. So this is an opportunity which we can continue even beyond COVID, and it's kind of empowering the community as a whole, and also at the same time strengthening the system so that they can respond further. So this is obviously a great opportunity where we can build the experience and just work on it.
Yeah, thank you, Sajja. Thank you so much. I'm going to leave it there and hopefully come back around. And if I can move over to Susanna, where we're going to talk a little bit about non-communicable diseases, particularly, and I know in Rory's slide, he mentioned that he put up that slide on India, but particularly in relation to conditions like diabetes and obesity, it doesn't get a lot of attention, particularly in low middle income countries, and yet incidence is increasing. And then particularly with the complications around COVID, how can we start to think a little bit more about the interaction of undernutrition, overnutrition? What are you seeing at the moment?
Thank you, Nadine, for having me around here. So as far as non-communicable diseases and undernutrition and overnutrition, we've always known that these are major problems in low to middle income countries, but they're even more important now given the current pandemic. We know, as far as we have the evidence, that nutrition plays an important role in the immune system. And in the case of undernutrition and overnutrition, we often can miss cases of poor immunity because of the underlying health issues. So let's take the example of overnutrition. This is something that's prevalent in a lot of the low to middle income countries, and it can easily mask nutritional, such as micronutrient deficiencies. And that could be a problem because we can assume an individual is healthy or simply is having an excess of calories and therefore potentially an excess of nutrient intake, when in actual fact they can be missing key micronutrients or vitamins that can protect their immune system. And in the case of non-communicable diseases such as obesity and type 2 diabetes, things get even more complicated because not only does poor nutrition contribute to poorer health and increased susceptibility to the COVID-19 infection, what we also know is that once a person is infected, you have the issue of how to manage their diet in terms of improving or maintaining their glycemic response. So there are multiple issues to be considered, and in the case of low and middle income countries, it's becoming even more complicated because we do not necessarily have systems in place that can accurately measure the individual nutritional status. As most of the panelists highlighted, there are now issues with the way we can measure the nutritional status of children or adults in general, and we do not necessarily have tools to be able to see if a patient who's admitted into a hospital is malnourished or not. And as far as, for example, Morocco, I'm working with some healthcare professionals in Moroccan hospitals, and what they're being faced by is that once a patient is admitted into hospital, if they do identify malnutrition in their case and they try to manage it, by the time the patient goes out into the community, there is no way of following up to see what's happened in terms of their nutritional status. And as has been highlighted in here, we're probably facing a future pandemic of malnutrition. So there is a lot of issues, and as I said, in these countries, the main issue is the lack of data. If we don't have data on the individuals and their nutritional status, how are we able to predict what could be the best solution in terms of managing their health or creating public health interventions?
Thank you, Susanna. And I wonder, I mean, obviously these are things that you're thinking about within the institution at the moment. I'm just wondering, do you have any suggestions for strategies, and what should people be thinking about, and how can they be incorporating the thinking around non-communicable diseases into their nutrition programs and planning?
I think the main priority is to not forget about nutrition. Often it is the case when patients are admitted into hospital or in general public health guidelines is to focus on treatment and managing the current problem, and nutrition gets secondary attention. So if we were to finally give nutrition its rightful place, we might be able to deal with the problem much better. And we are in desperate need of improved tools to be able to capture not only the dietary or nutritional status of the community or the country, but also of the individual. Because if somebody is able to come into the hospital and we know already from their nutritional status or analysis that they're lacking vitamin D, that they're lacking some key nutrients such as vitamin A, then we would be able to intervene correctly. But in the absence of these tools, it will be very difficult to design appropriate interventions.
Thank you, Susanna. I think it's really good food for thought for us to be really just thinking about non-communicable diseases. It's something that's often an afterthought, especially when we're dealing with in the fire of responding. I wonder if I could, maybe Rory, I could just move to you and see if do you have any questions that you've been thinking about that you could ask our panelists.
Thanks, Nadine. Two sort of related questions stimulated by what Mary was saying, but Sajja also talked to them. The first is they're both about balancing the risk of encouraging mothers and children to be visiting health facilities for essential services versus the risks of staying at home. And it sounds like, you know, the risks of staying at home are greater. And is this something which needs to be addressed through communication strategies? And the second is also a balance, and that's between WHO has advised us how to reprioritize services so that essential care for COVID needs to be provided. But are there risks whereby that staff and resources and effort get shifted away from essential services to respond to COVID? And yet being able to respond to COVID is probably essential to show that the health services are responding to a real need. I'd welcome if any members of the panel could just sort of talk to those in their final comments.
Great. The floor is open. Marie, I see you've unmuted. Go ahead.
Yeah, I think they're spot on questions, and they're the real dilemmas. And I think whilst there might be some opportunities, I think there's a real risk that nutrition gets sidelined in terms of attention, resources, and capacity. I think as much as possible, there's been a move as well to try and integrate nutrition within health systems and services, and universal health coverage very much speaking to that, but we're not there yet. And I think there is a risk. I think it remains there's 47 million children wasted in the world, less than a quarter of them are treated. And we don't get the same attention as a COVID pandemic. And I think it's interesting hearing the narrative about people saying we're going to have a pandemic of undernutrition. We're having to use the word pandemic in order to sort of get attention on nutrition somehow. So I think that is a real dilemma, I think, at country level, and the sorts of practical things that programs are doing are like looking at the sort of the triage, or how do we do, getting more nuanced. Who are the most at-risk kids in our community, and how do we prioritize them for access to services? Whether it's a kid who is sick or whether it's an infant that's born low birth weight, they're marked as a risk infant. We need to make sure there's a pathway of care for them. But I think there's a real risk of, as Sadia says, we've already in fragile and under-resourced and under-capacitated health systems and services. But I think the push towards the community, engage in the community and prevention, I think we undersell the prevention, and I think trying to get lifting the lockdowns, or as soon as possible trying to get that kind of the food security, the agriculture, all of those things that help to prevent. That means we're going to have less kids sick and wasted. And I think that is, again, that tricky balance. We're seeing it in all our countries, of when the compromise is that the balance of risk of COVID versus the balance of risk. And many of these countries saying, yeah, COVID, but we've got a million other things that are killing our population as well. And this is just something else. So I think that's what people are struggling with on the ground. But there is innovation, and there is that sort of prioritizing of children and services, but keeping nutrition on the in the services is going to be a real challenge.
Thank you, Marie. I wonder if we could go over to maybe to yourself, Sajan, in addition to maybe picking up on some of the points there in Rory's questions. I see there's also a question in there that surely there's a need to treat urban dwellers and rural ones differently in relation to attending facilities and interventions. Maybe you could pick that up as well. Thanks.
Yeah, I just want to add to what Marie already said, that about the fragile health system as just diverting the already limited resources to COVID response. There's another problem that we are facing, is that even if the services are available, actually the mother and the children are not coming in the fear of getting COVID. So that type of kind of communication, that type of how can we bring them to the health services? How can we build that trust? That's also another kind of challenges that we are facing. In relation to the urban and the slum, that's actually, I forgot to mention about that challenge, because when even we were trying to do we will do the no touch and we will maintain the social distancing in every services, we didn't find a solution for the urban areas, and even for the camps like Bangladesh. This is one of the biggest a refugee population, and it's so dense. We still are struggling. What can we do to make sure that the social distancing are maintained? And also, the way we are saying that, okay, if you have a COVID and if you have mild system, you should be isolated in your home. But if you look at the camp situation or the slum situation, it's not possible. It's not feasible. We still don't have any answer to that question or any solution to that problem. How can we make sure that in the slums or in the camps that we are working with, we can maintain the IPCs? So that's still, we are struggling to find a solution to that.
Yeah, thank you, Sajan. I see another question in there from Deirdre. We're talking a lot today about what's happening right now and just responding as best we can. But in terms of the longer impacts, what kind of solutions are we already thinking about in relation to food security and chronic malnutrition, and also any advice in terms of where resources should be spent, given that they're so limited? Question to anybody, really, any of our panelists. Saja, you're jumping in.
I just wanted to say I don't have any answer. Still don't know. We are still so many things that's unknown. We don't have enough data. We don't have enough resources to collect data. Or I mean, according to me, we still don't know the impact, but we can at least predict based on the data that already Timothy presented that what is coming. But
we are learning. I hear you. Saja, just as I'm with you right now, as I'm just moving through the panel, maybe you could just give us 2 takeaway points from today that you would leave us with and leave our attendees with. Just 2 very short takeaway points.
The first and foremost, nutrition should be the center for any responses, COVID or non-COVID. I mean, it doesn't matter. Every sector should make nutrition a priority because, as already Susanna said, it's going to be a pandemic. So that should be the key priority. And any type of activity we do, we need to gather we need to collect the knowledge, the lesson learned. We need to document, we need to know what we are doing and what are the impact. That's a huge gap. And for us even, we are not good at it. We are not capturing the lesson learned as much as we want to. So that will be the 2 key takeaways.
Thank you, Saja. Really well heard. Thank you so much. Coming to you, Timothy, 2 takeaway points. I mean, obviously you've been listening to the panelists as well, and obviously such great appreciation for the study you've done. 2 takeaway points for us today.
I don't have that much to add. I would say, you know, as per our research, I think the main thing is just that policymakers should be considering all the trade-offs here that are involved. And while we might not have, you know, good sort of evidence for cost benefits in terms of certain aspects, you know, there's clearly issues here which we've all discussed, and a potential for real health consequences on the indirect side of things. So I think we just have to keep that in mind. And then I think secondly, you know, use this as a time to innovate and think about how we can deliver services differently, how we can maintain services and kind of continue to build, and not just to, you know, during the pandemic, but also that might improve service delivery and healthcare more generally in the long term.
Thank you, Timothy. And we love that if also you could take away some modeling, including incorporating WASH, we know that we would really appreciate seeing more on that. So thank you for that. Susanna, just coming to you, 2 takeaway points for you.
I think the main takeaway point is that nutrition should be moving away from simply being a supportive tool or field in the case of medical treatment and management, and should be given a rightful place as a primary important public health issue that needs to be considered. And secondly, that we need better tools to capture nutritional status in low to middle income countries, so we could have data to handle this problem.
Very clear. Thank you so much, Susanna. And Marie, coming to you, just your 2 points for us to take away.
Thank you. I think the first one is get involved. You know, I imagine there's a rich resource of people watching this or will be watching this. You can help. Go to the GTAM website. If you can help in terms of sharing or experience or capture, and also share what you're doing, share what you're, you know, share the networks, etc. So get involved. You know, there's an awful lot you can do from afar. And I think secondly, just, you know, reinforcing the need for us to highlight nutrition is a key thing. There's a UN Global Action Plan on child wasting being developed. There's going to be a country roadmap. We need to keep our back into this, put our back into this, and keep the wind behind the sails on really getting child wasting. And this is reinforced the need for this. So I think really engaging and making sure nutrition remains on the agenda. I think we have to shout louder than we ever have had to, so that we sort of go forward on this and not backwards.
Marie, thank you so much, and thank you to each and every one of you today for just, you know, educating all of us and inspiring us all to be more passionate and shout louder on nutrition and malnutrition. Rory, I wonder if you have a takeaway point you'd like to share? No, we're good. Okay, excellent. Well, then I just want to thank our all of our speakers for an amazing panel today, and also particularly my colleague and friend Jacinta Green, who is the chair of the Nutrition and Health Study Group for DSAI, Development Studies Association of Ireland, who's co-hosting this with us today. A really important topic. Hala, I'll hand back to you.
Okay, thank you. Thanks, Nadine, and thanks to our speakers for sharing all those useful inputs about the connection between malnutrition and the COVID-19 pandemic. We hope to see you again in one of our coming webinars. Also, thank you to the DSAI Nutrition and Health Study Group for co-hosting this webinar with us, and we look forward for more collaborations in the future. Next webinar will be about COVID-19 pandemic and disability, and it will be interpreted into the Irish Sign Language live during the webinar. If you have any questions, please send them to our emails. And thank you also to all of our attendees for joining and interacting during the webinar. We hope to see you again in our coming webinars. The recording of today's webinar will be available in our YouTube channels, our website, and newsletter as well. And don't forget to check our COVID-19 portal with the best and most updated information on the global health and COVID-19. Thanks again, everyone, and see you again next week. Bye. Stay safe.
Thank you, everybody. Bye-bye. Thank you.
Thanks. Bye.
See you. Bye.